Chapter 37, Care of Patients with Diabetes and Hypoglycemia. So your theory objectives for this lesson are to be able to compare and contrast the two major types of diabetes mellitus, type 1 and type 2, to analyze the primary factors that influence the development of diabetes mellitus, to explain the signs and symptoms of an insulin reaction, hypoglycemia, and discuss appropriate nursing interventions for both. Summarize the acute and long-term complications and results of poorly controlled diabetes mellitus, and to identify sources of support and information for people with diabetes and their families. Clinical practice objectives include the reinforcement of teaching for a newly diagnosed person with diabetes about the disease, treatment, and self-care, to perform a focused nursing examination and gather data for the management of type 1 and type 2 diabetes mellitus, to interpret laboratory tests used in the diagnosis and management of diabetes mellitus, to gather data related to signs and symptoms that might indicate that the patient with diabetes is in early ketoacidosis, and to reinforce teaching about how to recognize and self-treat hypoglycemia. So type 1 diabetes mellitus is due to a malfunction of the beta cells. It's an autoimmune disorder. The body begins to attack and destroy the beta cells that produce insulin. With type 1 diabetes, there is a decreased production of insulin by those beta cells in the pancreas, and therefore you don't have enough insulin circulating in the body to allow the glucose to get into the cells and be used for energy. Type 2 diabetes mellitus is related to insulin resistance. So the body is producing insulin and is able to produce insulin, but the reaction to insulin with glucose becomes less efficient and the glucose metabolism is abnormal. So even though there's good circulating insulin, the cells are not able to react with insulin the way that they're supposed to in order to allow the glucose to come into the cell. And therefore, we have high circulating blood glucose. And there's gestational diabetes. The stress of pregnancy can cause a person to develop gestational diabetes. Typically, we do that glucose tolerance test with these patients about 28 weeks of pregnancy. Now, interestingly enough, if you have gestational diabetes, you actually have a 35 to 60% chance of developing type 2 diabetes within 5 to 10 years after having the gestational diabetes. Even though diet and exercise may really help with glycemic control, it will not reverse gestational diabetes. The only cure is to have the baby. And like I said, afterwards, you are at higher risk for developing type 2 diabetes. Pregnant women can take a exogenous insulin while they're pregnant to help control their blood sugar as well. Okay, so diabetes in general, so type 1 and type 2, there are genetic factors. They run in family. However, that being said, we see a lot of people with type 2 diabetes, their entire family having type 2 diabetes due to the things that they're eating, the exercise level that their family has. Metabolic factors, emotional and physical stress, being obese can put you at an increased risk for diabetes mellitus type 2. Some forms of type 1 may actually be related to a viral destruction of beta cells. They may start with some kind of microbiologic factor. And then the immune system in type 1 causes the destruction of those insulin secreting beta cells of the pancreas. Symptoms of type 1 diabetes. So these include the 3 Ps, which we do see in both types. Extreme thirst, which is called polydipsia, frequent urination, which is called polyuria, and extreme hunger, which is called polyphagia. Remember here, poly means many. So dipsia is thirst, uria is pee, and phagia is eat. So many thirst, many pees, many eats. And that is the 3 Ps of diabetes. Also with type 1 diabetes, we see a rapid loss of weight, irritability, weakness and fatigue, nausea, and vomiting. Incidence of type 1 diabetes, type 1 diabetes is very often genetic. There's a family history of type 1 diabetes. The person may have had an infection prior to the development of the disease. It is most common in Caucasians, American Indians, and Alaskan Natives. It is less common in African Americans, Asian Americans, and Hispanic Americans. Symptoms of type 2 diabetes. So we also might see those three P's, the polydipsia, polyuria, and polyphagia. However, more commonly, we see excessive weight gain in these patients. They get very heavy, they're obese. They have a family history of diabetes mellitus, poor healing of wounds, blurred vision, itching, drowsiness, increased fatigue, and neuropathy. And we see blurred vision and neuropathy and such due to the circulating sugar. So they have high levels of sugar in their blood. And we know that sugar actually causes damage to small blood vessels and nerves. And so therefore we have a high level of circulating sugar. And as it gets into the small blood vessels of the eyes, it is actually damaging them. And then the eyes are not getting enough oxygenation. Same thing with the toes and the fingers. There's nerve damage. There's also microvascular damage. And therefore, we have numbness and tingling sensation and sensory issues with some neuropathic pain. We also have damage to the capillaries in the peripheral small tissues. And therefore, we have peripheral vascular disease potential. So incidence of type 2 diabetes, there may be a family history, but it's not necessarily genetic. Often it's diagnosed in the older age, may have a history of gestational diabetes. We talked about that increased risk of developing gestational diabetes type 2 diabetes after you've had the gestational diabetes. So that is a potential. They also may have an inactive lifestyle or poor diet. It is very common in your African Americans, Hispanics, American Indians, Asian Americans, Native Hawaiians, and Pacific Islander populations. So how do we diagnose diabetes mellitus? Well, it's just a little bit tricky. We do a screening. We kind of get a good history and physical on the patient. We ask them what they're eating, how they're exercising. We ask about family history, right? All of that's going to help us to narrow it down. And then we need to do a hemoglobin A1C. Hemoglobin A1C is going to tell us what their sugar has been over a period of several weeks, and we'll get a good idea of their glycemic control. We may also do a fasting plasma glucose where we want them to not have anything to eat the night before or morning of, and then they come in and we draw some labs and see what their sugar is. If that is elevated, we may be concerned that they have diabetes. And the last really common option is the 2-hour 75-gram oral glucose tolerance test, or the OGTT. And when we give a glucose tolerance test, we want the person not to have anything to eat before or during the test. They're going to drink the glucose solution, and then we'll test their sugar 2 hours later to see how much of that glucose has been taken out of the blood to see if they may potentially have developed diabetes. And so these three, the hemoglobin A1C, the fasting plasma glucose, and the 2-hour glucose tolerance test are direct indicators of diabetes. Now, if we get a random blood glucose level, that's not a direct indicator. However, if it is really high, let's say 300s, 400s, there is a good chance that this person has diabetes. I mean, you don't get a 300 or 400 glucose and not have an underlying pathology. So even though it's not a direct indicator of diabetes, it's definitely indicative of diabetes. So just keep that in mind. So you have to have symptoms. So some of those previously mentioned symptoms like weight gain, or polydipsia, polyuria, polyphagia, or a peripheral neuropathy or eye blurred vision, right? And a random blood glucose level greater than or equal to 200 milligrams per deciliter, a fasting glucose level greater than or equal to 126 milligrams per deciliter, or a glucose tolerance test that reveals a postprandial glucose that's greater than or equal to 200 milligrams per deciliter 2 hours after you give that 75 grams of glucose. We talked about this a little bit. The patient is given a set amount of glucose to evaluate their insulin secretion and ability to metabolize glucose during a glucose tolerance test. Hemoglobin A1C measures that blood glucose over a period of many weeks. Glucose in the bloodstream attaches itself to the hemoglobin A, or the red blood cell molecule, and it remains there for the lifespan of the red blood cell. Physicians use that hemoglobin A1C test to prescribe adjustments to the patient's treatment program for managing diabetes, because it's going to show us how much glycemic control that we have. Healthy People 2020 had a goal of increasing the proportion of adults with diabetes who have that A1C test at least twice a year to check on their glycemic control. And then there's a test called fructosamine assay. We don't use this as much. It monitors blood glucose over a shorter time frame than the hemoglobin A1C test, maybe 2 to 3 weeks, because the assay measures sugar attached to the protein albumin, which has a shorter lifespan than the hemoglobin. So I have a few videos for you I'd really like to share, and I want you to pay special attention to both the explanation of sugar and insulin reaction, right? Glucose and insulin reaction. Remember, insulin is what allows the cells to use that glucose as fuel. It's the key that opens the cell. And then also pay attention to the diabetes ketoacidosis. It is a very serious complication of diabetes, specifically type 1 diabetes. I will play those videos now.
Waiters always look at me and think that I'm going to have a little salad, maybe a soup, and that'll be the whole meal. And when I do my actual order...
Understanding type 2 diabetes. Type 2 diabetes is a metabolic disorder that causes sugar, in the form of glucose, to accumulate in the blood rather than being used as fuel by the cells in our body. When we eat, food is broken down by our digestive system into nutrient molecules that are then absorbed through our digestive tract for use by the body. Foods containing carbohydrates or various sugars are broken down into glucose. Glucose is an important source of fuel for many organs in our body. However, to be able to use the glucose for fuel, the glucose molecule must first enter into the cell. The pancreas produces a hormone called insulin, a chemical messenger essential for the entry of glucose into cells. As the blood glucose levels rise after a meal, insulin is released into the bloodstream and sets processes in motion to trigger the removal of glucose from the blood to enter into the cells. In type 2 diabetes, the cells become resistant to insulin and ignore its message to absorb glucose. This is known as insulin resistance. In addition, in type 2 diabetes, the pancreas is unable to produce the greater amounts of insulin needed to trigger these resistant cells to take in glucose from the bloodstream. The most notable symptom of diabetes is frequent urination and excessive thirst. Other symptoms include weakness, drowsiness, and blurred vision. These are caused by chemical imbalances in the blood related to high levels of blood glucose. About 1 in 4 people with type 2 diabetes are unaware that they have the disease. It is important to catch diabetes early. Over time, high blood glucose damages the blood vessels, which can damage the organs that these vessels supply, leading to a variety of health complications. Damage to the small or micro blood vessels can cause vision problems, including loss of sight, nerve damage, and kidney disease. Damage to larger or macro blood vessels can lead to cardiovascular complications such as heart disease, stroke, and poor blood circulation. Overweight and inactivity are major causes of diabetes. A family history of diabetes significantly increases your risk of developing the disease. Certain ethnic populations are also at increased risk of developing type 2 diabetes. Finally, some medications may increase your diabetes risk, specifically corticosteroids, thiazide diuretics, drugs used to treat certain mental illnesses, and some antiretrovirals used to treat HIV infection. In summary, type 2 diabetes is a metabolic disorder. It causes sugar, in the form of glucose, to accumulate in the blood, rather than being used as fuel for the cells in our body. If not diagnosed and treated in a timely manner, type 2 diabetes can lead to many health complications.
You ever wondered what
So you have type 1 diabetes. It's something you're going to manage, mostly with insulin, a hormone your body doesn't produce when you have type 1 diabetes. By now, you probably know how and when to give yourself insulin. And if you have an insulin pump, you probably know how to maintain it. But do you know how to tell if something's not working? That's what we'll be looking at. You eat carbohydrates to fuel yourself with energy. Your body breaks down the carbs into sugar, which then goes into your blood. Think about it like filling up the gas tank in a car. When you eat, your body stores the carbs to use as energy when you need it later, like filling up the gas tank. Insulin is what opens the tank to let the gas in. As someone with type 1 diabetes, you don't produce insulin naturally, so the sugar doesn't get to where it's supposed to be, which is why you take insulin. If you're not getting the insulin you need, the sugar you eat stays in your blood instead of being stored in the tank. When this happens, your body won't have the fuel it needs when it needs it, and your body will seek out alternative sources to break down into fuel. One of the first sources it looks for is fat. Except when your body breaks down fat, it leaves ketones in your bloodstream that make your blood acidic. Together with high blood sugar, acidic blood from the ketones can make you sick and put your body in a state of diabetic ketoacidosis, or DKA. And DKA is really serious. It can even be fatal. The most common reasons for DKA happening are developing type 1 diabetes, missing taking your insulin, getting an infection, and malfunctioning equipment. Your body will give you plenty of pre-DKA warning signs before you're in serious danger. You may pee more than usual, which is your body getting rid of the sugar that isn't making its way into your cells. You may feel thirstier than usual, which is your body diluting the unused sugar in your bloodstream with water. You may find yourself breathing faster, which is the way your body tries to compensate for acidic blood. And you may feel tired and weak. If you notice any of these warning signs, check your blood sugar and also check your blood or urine for ketones. If you are worried or you're not sure what to do, call your diabetes care team or go to the hospital. Remember these easy steps to prevent DKA. Test your blood sugar regularly. Always take your insulin even when you're sick. If you are sick, stay hydrated and you may need to take more insulin than normal. If you wear a pump, check regularly to make sure it is connected and working. And if you notice any of the DKA symptoms, check your blood or urine for ketones. Want to know more about DKA? Have other questions about managing your diabetes? Ask your diabetes care team and stay tuned for more videos to help you stay healthy and continue to live the life you want.
Congratulations! You're in nursing school. Have you heard about pharmacology? Well, if you
What is going on, guys? Ben checking in. Welcome to Mint, where we bring nursing to you. So today we're going to be talking about diabetic ketoacidosis or DKA in 5 minutes. So if you're ready, I'm ready. Let's go.
Hello guys, welcome to this video. Today we will talk about diabetic ketoacidosis or DKA in 5 minutes. There are 5 hallmark signs that characterize DKA. They are hyperglycemia, ketosis, acidosis, dehydration, and electrolyte imbalance. But first, let's talk about the pathophysiology of DKA. Normally, we have glucose in our bloodstream. Now, our cells need glucose to function properly and to get energy. Now, for this to happen, our glucose needs to get transported from the bloodstream into the cell. And this is made possible by the insulin that is secreted in the pancreas. It binds to glucose, which allows the transport of glucose into the cell. Once the glucose is in the cell, then we have energy. So that's normal. In diabetic ketoacidosis, there's not enough insulin or there is no production of insulin at all. So the transport of the glucose into the cell does not occur. This results in elevated blood glucose, and because glucose is unable to enter the cells, there is no energy. To make things worse, the body will try to compensate by taking glucose from the liver and transporting it into our bloodstream. This happens because the cells are hungry. Because there is no energy, it thinks that the body does not have enough glucose. So now the body is still hungry for energy. So what it will do is that it will break down fats and convert it into energy. Now these energies are used by the cells. But in the process of breaking down fats and converting them into energy, the body produces ketones, and these ketones get stuck in our bloodstream. Now, this is what's causing our ketosis. Now, let's talk about the clinical manifestations of diabetic ketoacidosis. Now, these signs and symptoms occur because of these 3 occurrences. We have the cellular starvation, or the cells are hungry. We have the increase of blood sugar in the bloodstream, and the presence of ketones in the bloodstream. First is the altered mental status. Because the glucose are not able to get in our cells, our brain cells are deprived of glucose and energy, which causes altered mental status. Some patients become lethargic and drowsy. Now, another thing is weakness. Our muscle cells are also glucose deprived, which causes weakness. Now, another symptom is polyphagia or hunger. Now, because our cells are glucose deprived, our cells will send signals that we are hungry. Another symptom is polyuria. This is the body's compensation to get rid of the excess glucose and ketones in the system. Now, here's the thing about polyuria. We're not only urinating the excess glucose and ketones, but at the same time, when we have excessive urination, we're excreting the potassium and other electrolytes in our system. So this causes electrolyte imbalance. The next is polydipsia, or excessive thirst. Now, this occurs because of the polyuria. We are urinating too much, which causes dehydration. Again, the brain will send signals that we are dehydrated. Thus, the body will say that you are thirsty. Another symptom is the metabolic acidosis. Now, the body becomes acidosis because of the presence of ketones. Now, too much of these ketones are very toxic. That's why the body becomes acidotic. So a lot of patients, you'll see that their pH is less than 7.35. Now, another compensation of our body to get rid of the excess ketones in the system is through Kussmaul breathing or Kussmaul respiration. So this is what's causing the fruity breath smell and rapid respiration. You're going to remember all of these clinical manifestations by thinking of those 3 occurrences: the hungry cell, the presence of glucose in the bloodstream, and the presence of ketones. Now, let's talk about how to care for a patient that has diabetic ketoacidosis. Now, there are 3 things that we have to focus on for a patient that has diabetic ketoacidosis. Number 1 is hydration. So when a patient comes into our ER and you see the signs and symptoms of diabetic ketoacidosis, you're going to establish an IV and hydrate with fluids right away. Initially, it's going to start with NS or half NS, depending on what the doctor orders. Now, once the blood sugar is near 250, switch the fluids to dextrose to prevent rapid drop in sugar, which may lead to cerebral edema. So the next priority is the electrolyte correction. Once the labs are there, you have to correct potassium if it's low. Now, if the pH is less than 7, then some doctors would order bicarb. Remember, the presence of ketones makes our body acidotic. So lastly is the insulin administration. So the doctor will probably order insulin drip for a patient. So the very important thing as nurses, what you have to do when a patient is on insulin drip is to monitor blood sugar level. To summarize the care for a patient that has DKA, we have hydration, electrolyte correction, and insulin administration. And that's it.
Well, that is it for today, guys. I hope you guys enjoyed the video. If you haven't already, please hit the like and subscribe button. By doing this, our videos will go straight to you. Make sure you
Okay, so I feel like that was a lot of videos, but they were good videos, especially the ones on diabetic ketoacidosis. So how do we manage diabetes mellitus, or how do we teach our patient to self-manage diabetes mellitus? Well, we want to talk to them about the benefits of tight glycemic control, making sure that we keep that sugar nice and snugly in that happy range, right? Usually less than 150 is the goal. Hypoglycemia, teaching them about the concerns about hypoglycemia, what signs and symptoms to look for, to try to find a fast sugar to raise their glucose, something like an orange juice, 4 to 6 ounces of orange juice, or a hard candy with sugar. And then also about insulin reaction, making sure that before they give their insulin, they're prepared to eat directly afterwards. Otherwise, they can cause an insulin reaction and bottom out their sugar. The overall goal of diabetes management is to keep that sugar from causing additional damage or issues within the body. And the older adult is more likely to have those hypoglycemic episodes, so keep a close eye on them. Diet is the cornerstone of diabetic treatment. So teaching the patients that low carb foods are best, that we don't want any simple sugars in the diet if at all possible, and really emphasizing the foods that are allowed on their diet rather than those that they cannot have. Hypoglycemia is a potential side effect or complication of exercise. So if they're going to exercise heavily, it's important that they know to increase their food intake because their body does not respond to sugar the same way that other people's bodies respond to sugar. A lot of people think that if they eat that low carb diet, their sugar won't go up. Well, whenever we eat, despite the amount of carbs or sugar in the food, our sugar will go up a little bit. So we expect to see a rise in blood glucose whenever there's ingestion of food. Oral hypoglycemic agents can be given, including metformin. Some of the more common ones are glyburide, repaglinide, rosiglitazone, and all of those can be given, but we want to make sure with those 3 medications that we're watching the sugar level because they may have a higher risk of hypoglycemia with those medications. Some medications you don't have to worry about hypoglycemia. For example, metformin and acarbose, we don't worry so much about hypoglycemia. So we're not checking their sugars to make sure that they're not going to bottom out with those medications. But the glyburide, repaglinide, and rosiglitazone, we're really concerned. They require blood glucose monitoring for hypoglycemia. And then the acarbose is human-made. It's an oligosaccharide, and it helps to slow down the action of the alpha amylase and alpha glucosidase enzymes, and thereby it slows the appearance of sugar in the blood after a meal. It won't actually cause hypoglycemia. And metformin is kind of similar in that it influences the uptake of insulin at the receptor site on the cell. It doesn't actually influence insulin production, and therefore it's not going to cause hypoglycemia. Insulin therapy, obviously we give exogenous insulin as well via injection or a pump, right? Insulin therapy, the goal is to closely mimic that basal or baseline in the body insulin. We want to do multiple daily injections unless we have an insulin pump. Obviously, an insulin pump is better. Same thing with monitoring the sugar. It's better to have that CGM or continuous glucose monitoring device like a Dexcom in order to tell us what the sugar is at any given moment within a range of error, versus sticking over and over and over again to check sugar to make sure we're okay. Patient teaching is super important. We need to make sure that patients know what they should be eating, how they should be treating themselves with the insulin, and that they need to eat after they give the insulin. That way they don't have an insulin reaction. We need to monitor their compliance with their medication regimen, make sure that they're not insulin rationing, right? Because insulin is very expensive. That's a thing that's happening now, or giving themselves an insulin that's not designed for humans, like the dog insulin you can get at Walmart. Teaching them insulin to carb ratios. Usually, 1 unit of insulin covers about 15 grams of carbs. So if they're on a ratio type insulin therapy, we can teach them how to cover their carbs. And then the other medications that they're on, we want to make sure that they have knowledge of what might cause hypoglycemia and which ones they have to monitor their sugar closely with. It's important to rotate sites of injection of insulin so that it's, first of all, comfortable. Second of all, using the same site can cause breakdown or hardening of the injection site. So you may either have a hardening called lipodystrophy. It may either be a lump or a bump or an indent, and it can interfere with the absorption of the insulin and therefore its effectiveness. There's a picture of an insulin pump. Islet cell transplantation. So this is usually for your type 1 diabetics that are unresponsive to other interventions. You need 2 to 4 donor pancreases in order to accomplish this, and therefore it's considered somewhat wasteful. There's an ethical implication to this. Will this patient be compliant? Will this be worth it for this patient? Ethically, can we waste 2 to 4 pancreases or use 2 to 4 pancreases to accomplish this transplant for this patient? What does their prognosis look like? About 1/3 of recipients will actually develop antibodies, which will prevent any future whole pancreas transplants. So it better be good, right? It better stick and work for them. Lifetime immunosuppressant medications are needed, and they're also highly nephrotoxic, so they can cause issues with the kidneys. So this islet cell transplantation is really used for the most extreme cases. Nursing management for diabetes, we want to monitor that trend in the blood glucose, the hemoglobin A1C, the fructosamine assay to make sure that we've got good control, good compliance. We also want to watch for hypoglycemia after an insulin injection. Look for that cold, clammy, sweaty diaphoresis, right? We see that a lot afterwards. Changes in level of consciousness, confusion, which would indicate we would need to intervene. As long as the patient is able to swallow, we want to do a fast sugar like an orange juice or a hard candy. If they're not able to swallow, we need to talk about other options, things like giving dextrose IV, right? Monitor for signs of ketoacidosis as well. Also confusion, maybe some of those Kussmaul respirations that breathe off the sugar. We want to smell for that fruity, acidic breath. There's a picture of the blood glucose monitor, one of the many that it may be used. When there is doubt, is it hyper or hypoglycemia? This person has gone down. We always want to treat as hypoglycemia until we can get a blood glucose, okay? Rapid determination of blood glucose is very, very, very important so that we know how to manage the condition, because we treat them opposite, right? So if they go down and they're actually hyperglycemic, if we don't get a blood sugar to determine that quickly, then we're going to be treating them as hypoglycemic, and we may actually raise their sugar more. Hyperglycemia is a lot slower. So when a patient passes out very quickly, it's more than likely hypoglycemia. Hyperglycemia does not cause those immediate changes in level of consciousness that we see. And hypoglycemia can occur very rapidly versus the hyperglycemia's slow development. When a patient is admitted to the hospital with hyperglycemia, we have to make very quick decisions about how to treat based on their objective and subjective symptoms. And in the type 1 diabetes, they're more likely to get ketoacidosis, whereas the type 2 diabetics are more likely to get hyperglycemic hyperosmolar state. So let's talk about the two of those. Diabetic ketoacidosis, which is what we watched our video on, is a serious condition caused by the incomplete metabolism of fats that result from an absence or insufficient supply of insulin. So when insulin is not present in adequate amounts to meet the metabolic needs, the body begins to break down protein and fat for energy, right? Think keto diet. This produces an abundance of the byproducts of fat metabolism, which are potent organic acids called ketones. In order to rid itself of the acidosis that's produced by the ketones, the body increases its respiratory rate and depth. It's trying to breathe off the acid. It's called Kussmaul respirations. And they've got that fruity breath, right? Signs and symptoms of DKA. In the absence of insulin, potassium is going to come out of the cells, and the patient will have hyperkalemia on their CMP or BMP. They'll also have increased thirst, increased urination or polydipsia and polyuria. They'll have that fruity acetone breath odor, dry mucous membranes, sunken eyeballs due to dehydration. They may have nausea and vomiting. They'll have those deep respirations or Kussmaul respirations, abdominal pain and rigidity, paresthesias, weakness, paralysis, hypotension, minimal urine output or oliguria, or none anuria. So we see the polydipsia and the polyuria at first, and then as it's getting later in the DKA, they lose their output as they become extremely dehydrated. And then they may also become stuporous or comatose, which is extremely late as well. What do we want to do with DKA? Well, we want to restore the normal pH, right? We want to get out of that acidotic state. We also want to correct the fluid and electrolyte imbalances that are happening, like the hyperkalemia. We want to lower the blood glucose level gradually, and we want to provide life support measures as necessary, like protecting the airway. Patient teaching. We need to teach patients the pathophysiology of diabetes, including the functions of the pancreas and contributing or precipitating factors in the development of diabetes. We also want to teach patients how to manage a diet program, blood glucose monitoring at home, how to take care of their feet, not to cut their toenails, right? Because if they cut something, they're very slow healing. They also have peripheral neuropathy, so they're not going to be able to feel their toes very well. Urine testing, when their blood glucose level is really high, like 240, they're going to be checking for ketones in their urine. And if they're spilling ketones, then we're concerned about the development of diabetic ketoacidosis. They also need to have some kind of tag or medical alert bracelet, an identification card, etc. Information on what to do on their sick days, especially when they're nauseated or vomiting and they're not able to eat. We may see decreased blood glucose on those days. And if we continue the insulin administration, then we're going to have issues with bottoming out their blood sugar. We also want to teach them community resources and help groups that are available within the community for diabetes and their family. Travel tips, especially like packing snacks on while they're in the car for long periods of time, and teach them about their devices that will make insulin administration easier, like insulin pumps, especially for your older adults that are either visually impaired patients or patients that have arthritis and less hand dexterity. So short-term complications of diabetes, we've got hyperglycemia, hypoglycemia, and then we have this hyperglycemic hyperosmolar non-ketotic syndrome. So let's talk a little bit about this hyperglycemic hyperosmolar state, or HHS, which is a complication of diabetes. So usually when the patient has a low blood pressure, high heart rate, and a diagnosis of type 2 diabetes, and they present to the emergency room, we want to look for hyperglycemic hyperosmolar state clue-ins, right? High blood glucose levels are going to cause, and then we have an increased urination. So the patient is going to become extremely hypotensive and tachycardic as their body is compensating for the low volume. They're also going to have an increased respiratory rate and be in a ketotic state. They won't have the increased respiratory rate and be in a ketotic state unless they have the diabetic ketoacidosis. So think high heart rate, low blood pressure due to decreased volume in that hyperglycemic hyperosmolar state, and think acidic pH, so low pH, increased respiratory rate, and ketosis with that diabetic ketoacidosis. Okay. Rebound hyperglycemia. So this is when the patient wakes up in the morning and, that dawn phenomenon. So rebound hyperglycemia is actually when we treat the patient and then they develop a high glucose after we have given a treatment, right? And then the dawn phenomenon is when we wake up in the morning and we're either hypoglycemic or hyperglycemic in the morning time due to no control overnight or poor control overnight. Long-term complications, cardiovascular disease, metabolic syndrome, nephropathy, peripheral vascular disease, retinopathy, and diabetic neuropathy as well. Hypoglycemia, any condition that affects the intestines, liver, pancreas, and their systems can actually lead to hypoglycemia as well. So this is not related to diabetes. This is just general hypoglycemia, not getting enough sugar in your bloodstream. Gastrectomy or surgical bypass can result in hypoglycemia. Once again, we're really wanting to have snacks on board so the patient doesn't bottom out their sugar, making sure they're bringing cheeses and jerkies and things like that with them when they go shopping or on travel trips. Tumors of the pancreas or insulinomas can cause hypoglycemia, liver disease, disorders of the adrenal cortex, the pituitary gland, alcohol abuse or other substance abuse can cause hypoglycemia. Patients end up with a rapid heart rate. They are very tremulous, so they have tremors, they're weak, they're anxious, they're nervous, they may be hungry. We check their blood glucose. We can also check their insulin and C-peptide levels. If an insulinoma is suspected, we can do a CT or an ultrasound to identify that in the pancreas. We also want to modify their eating patterns, have them take smaller, more frequent meals in, keep it relatively free of simple sugars because that causes that huge sugar crash, right? High protein, low carbs, especially nice complex carbs like fruits, veggies, and whole grains. And then we don't want to put them on refined sugar or white flour. So here's a case study for you guys to follow along with. Mr. Gennaro is a 61-year-old Mexican-American male. Mr. Gennaro has previously been diagnosed with coronary artery disease and hypertension. He has newly diagnosed diabetes and accompanying hyperglycemia. Mr. Gennaro speaks Spanish and uses a medical interpreter. He smokes 1 pack of cigarettes per day and has smoked for 35 years. He has been prescribed regular insulin, Humulin R. He sees a curandera as an alternative therapy. A diabetes educator has been consulted by the attending physician. So he's that 61 Spanish-speaking man, presents to the ER with his wife, Dolores. Mrs. Genaro is also Spanish-speaking but understands some English. Mr. Genaro complains of nausea and vomiting for 2 days and symptoms of confusion. His blood glucose is 796 milligrams per deciliter. IV insulin is prescribed and he's admitted for further evaluation, and he will require lots of teaching regarding his newly diagnosed diabetes. His hemoglobin A1C is 10.3%. He's slightly overweight and he's 5'10" and weighs about 174 pounds. He reports no form of regular exercise and he does not follow a special diet at home. He states, "I eat whatever Dolores puts in front of me. She is a good cook." For the past few months, Mrs. Genaro has noticed that her husband has been very thirsty and has been up and down to the bathroom 100 times a day. Neither can recall how long it's been since these changes in Mr. Genaro began. Dolores states, "It's been quite a while now. It just seems to be getting worse and worse." The nurse does not speak Spanish. Discuss what the nurse should keep in mind to facilitate effective communication. So one thing we need to think about here is bringing in an interpreter, right? Or a MARDI device so that we can effectively communicate with the patient. Describe the following serum glucose tests used to help confirm the diagnosis of diabetes mellitus. So casual is like a random glucose test, right? We're going to check what it is right now. Fasting is when we haven't had food on board. It is a direct indicator of diabetes. Postprandial is after we've eaten to see how our body has taken up the sugar. And an oral glucose tolerance test is a more direct indicator that's going to tell us how the body processes glucose on a regular basis. When evaluating Mr. Genaro's postprandial result, what is important to consider regarding his age and tobacco use? Well, we know that blood sugar rises with age, right? It's normal for it to go up, your baseline blood sugar, over a period of time, and that tobacco use can increase blood sugar. The hemoglobin A1C test will tell the healthcare provider how well the blood sugar has been controlled over a period of several weeks. So having a high hemoglobin A1C tells us this has been going on for quite some time. How might the nurse briefly explain what diabetes is in lay terms to Mr. and Mrs. Hanaro? Make sure that you're using language, first of all, that translates well. Second of all, very simple language. You always want to assume that your patient can understand about a fourth grade level. So make sure that we're not using a bunch of medical jargon and we're explaining everything in layman's terms. Explain the difference between type 1 and type 2 diabetes and who's at increased risk for developing each type. So we already talked about this in lecture today, but this would be something great to dive into. And I'm actually going to leave the rest of these questions to you guys. If you can work on this case study, you're going to have a better understanding of diabetes. So I'll give you a second to maybe screenshot these pictures, or excuse me, screenshot these questions and work on them to increase your understanding of diabetes. Lots of good questions about foot care, wound healing, diet, exercise, complications. Here's the next page. Sick days, alcohol use, lifestyle considerations. Okay, guys, and that is it for the chapter 37 PowerPoint. I will see you in class this week, week 1. Woohoo!